So aortic size is thought to be one of the most important risk factors for aortic dissection based on the seminal hinge point theory proposed by Cody et al. In the 1990s. But in assessing the IRAD registry, we find that 60% of dissections are less than 55 millimeters, and roughly half have no discernible risk factor whatsoever. Clearly, size is not the answer. Newer studies have started to investigate that an interplay of size, structure, and hemodynamics may predict dissection. However, such measurements are complex and rarely usable as a clinical point of care instrument. To overcome this, we theorize and investigate that a simplified matrix of surrogate markers for vessel instability and shear stress may improve the predictability of complications compared to diameter alone. This is a retrospective cohort analysis of all patients who underwent aortic intervention at Waikato District Health Board in New Zealand from January 2015 to December 2019. These patients were identified into dissection and non-dissection categories. A multivariable logistic regression model was built using the demographic data and verified using propensity score matching, taking dissection as the outcome and using vessel instability, shear stress, and diameter as predictors. Each predictor was assessed as both a continuous outcome and as a binary variable above and below a hinge point determined with Brock curve analysis. Aortic measurements were measured in all patients at 9 different points using the European Society of Cardiology guidelines in short axis measurements on CT scans. For dissection patients, this was at the time of presentation, and for non-dissection patients, this was at the time of preoperative workup. Using well-established formulae, we developed surrogate markers. To assess vessel instability, we used ratios comparing the maximal aortic diameter to other points within the aorta. To assess shear stress, we used a ratio of aortic radius and patient height. We screened 2,436 patients, of which 215 patients were eligible to be included for this analysis. 78 patients were dissections, 137 patients were no dissections. The patients were mostly male with demographics as listed. The distribution of diameters between dissection and non-dissection patients demonstrated through the box plots appeared largely similar. However, as shown in the histogram, the majority of dissection patients had a diameter less than the current threshold for intervention. 65.3% of these non-bicuspid and 60% of bicuspid valve patients had a maximal aortic diameter less than 55 millimeters and 45 millimeters, respectively. In the multivariable model, aortic diameter, vessel instability, and shear stress were assessed as predictors of dissection. Both maximal aortic diameter and shear stress did not predict aortic dissection. Vessel instability, as the maximal aortic diameter to sinus of Valsalva ratio, were significant predictors for aortic dissection. A ratio above the hinge point of 1.06 conferred 4.5 times the odds of aortic dissection. This was also assessed visually, where we can see that this ratio is the only ratio with 95% confidence intervals above the odds ratio of 1, suggesting statistical significance. The implications of these findings were assessed using clinical measures of association. If we assume that size is a predictor of aortic dissection, then only 16.8% of dissections amongst dilated aortas are due to the aortic dilation itself. We would need to operate on 18 patients with dilated aortas to prevent one aortic dissection, and this is not statistically significant. By comparison, if we assume that maximal aortic diameter to sinus of Valsalva ratio greater than 1.06 causes aortic dissection, then 50% of dissections amongst those with an elevated ratio is due to the ratio itself. We would only need to operate on 2.7 patients to avoid one aortic dissection. As a measure, it has far better sensitivity at 73% compared to 33% of diameter alone, and much better receiver operator curve statistics as shown in the graphs on the right. The biggest strength of this finding is the magnitude of its effect. The effect is easy to use and statistically well validated. The limitations are that association does not imply causation. Secondly, as with all aortic studies, it's difficult to attain an appropriate control group, and for dissection patients, the dimensions were taken at the time of dissection. The conclusions are that the maximal aortic to sinus of Valsalva ratio greater than 1.06 confers a 4.5-fold increase in the odds of dissection. As a test, it has 73% sensitivity compared to 33% sensitivity of aortic diameter alone. The number of interventions needed to avoid one dissection with this ratio is far lower at 2.7 compared to 17.9, and aortic size is not a reliable predictor of aortic dissection. Thank you.
Hello, my name is Arnaldo Di Magli. I am a research fellow in Bristol. I would like to thank SCTS for the opportunity to present this work about neuroprotective strategies in acute aortic dissection, an analysis of the UK National Adult Cardiac Surgical Audit. We don't have any conflict of interest to declare. Management of type A acute aortic dissection remains challenging, mainly due to the risk of brain injuries, as in many cases, surgical repair requires a period of circulatory arrest, which is associated with a high rate of neurological complication and reduced survival. There is still no consensus on which neuroprotective strategy should be preferred among deep hypothermic circulatory arrest, retrograde cerebral perfusion, and antegrade cerebral perfusion, either unilateral or bilateral. Therefore, we conducted this analysis to investigate the association between neuroprotective strategies and clinical outcomes following type A acute aortic dissection repair in a nationwide UK-based population. Our primary endpoint was a composite of in-hospital mortality and postoperative cerebrovascular accident. Our secondary endpoints were in-hospital mortality, postoperative cerebrovascular accident, postoperative dialysis, and re-exploration for bleeding. We interrogated the National Institute for Cardiovascular Outcomes Research, National Adult Cardiac Surgical Audit, to identify patients undergoing type A acute aortic dissection repair from 2011 to 2018. A generalized linear mixed effect model was used to investigate the effect of neuroprotective strategies on the primary endpoint. We identified 1,949 patients undergoing surgical repair for type A acute aortic dissection, and the most commonly adopted neuroprotective strategies was deep hypothermic circulatory arrest, followed by bilateral antegrade cerebral perfusion. This latter group was characterized by a higher risk profile, and these patients were more likely to undergo longer cross-clamp time and circulatory arrest time. We found a positive trend toward lower incidence of our outcome of interest in the unilateral antegrade cerebral perfusion group compared to the other neuroprotective strategies. In particular, this potential advantage was confirmed only in those patients with a circulatory arrest time shorter than 30 minutes, whereas in patients with circulatory arrest time longer than 30 minutes, the incidence of these outcomes were comparable among the four groups. This trend was also confirmed when we further stratified for the concomitant use of deep hypothermia combined with other neuroprotective strategies. Therefore, we found an increased risk of death and cerebrovascular accident in patients in which deep hypothermic circulatory arrest only was adopted, compared to those patients undergoing surgical repair with adoption of antegrade cerebral perfusion, either unilateral or bilateral. No difference was found with retrograde cerebral perfusion. Interestingly, we found an interaction between unilateral cerebral antegrade cerebral perfusion and circulatory arrest time, with a steep increase in the risk of death and cerebrovascular accident in those patients with a circulatory arrest time longer than 30 minutes. This trend was not significant for retrograde cerebral perfusion and bilateral antegrade cerebral perfusion. Concluding, we found that the use of unilateral antegrade cerebral perfusion was associated with remarkable improvement in clinical outcomes when compared to the traditional approach based on deep hypothermic circulatory arrest only. This result should give a pause to concerns on unilateral cerebral perfusion and support a wider adoption of this technique. As most of the patients require circulatory arrest within 30-40 minutes, unilateral antegrade cerebral perfusion should be considered in most cases, while bilateral antegrade cerebral perfusion remains the preferred choice if a prolonged circulatory arrest time is anticipated. Thank you for your attention.
Sorry, was I muted then? Sorry about that. Thank you, Dr. Di Magli. That was an excellent talk. Thank you very much. Can I just say to people, please don't be afraid to put questions on the Slido. We do have time for questions, so please feel free. Can I just ask you, did you have any detail about cannulation strategy and whether or not the antegrade cerebral perfusion patients also had axillary cannulation, or whether it was a direct cannulation of the carotid arteries? Do you have any breakdown of that at all?
So yeah, no, unfortunately, we don't have this information in the dataset, so we're not able to say whether the antegrade cerebral perfusion was through axillary arteries or direct cannulation, unfortunately. But of course, this data would be much needed in order to give a overall better picture of this. Thank you.
Okay.
You know, sir, I also enjoyed your presentation, and
Thank you.
it's very curious because, you know, certainly some studies have shown unilateral to be equivalent to bilateral for prolonged circ arrest beyond 40 minutes. And do you have an idea as to why the results of this particular study showed otherwise? Or do you think it was just difficult to tell because, as Dr. Harrington was saying, the lack of granular detail on the cannulation strategies?
Yeah, well, there may still be some bias in the analysis itself, which could have led to these results. For example, we need to acknowledge that like more than 50% of patients receiving antegrade cerebral perfusion also like receive a deep hypothermia circulatory arrest. So this could have like led to better result. And moreover, if we look like at the complexity of the anatomy of the dissection, patient receiving antegrade cerebral perfusion were those with the less complex anatomic complexity. So like, for example, ascending interposition graft, whereas like bilateral antegrade cerebral perfusion was much more frequent in patients requiring full arch replacement. So this could be the reason, yeah.
And can I also ask, did you also look at temperature at all? Did you look at temperature that circulatory arrest was performed at?
Okay, so we consider, so in the data set, there is only like moderate hypothermia or deep hypothermia. So we don't have the information exactly on the core temperature. So we assume that by deep hypothermia, we mean like around 20 degrees of left, but we don't have the exact number on the core temperature.
Okay, thank you.
Thank you.
Thank you very much. Thank you. Okay, so I think we'll move on to our next speaker, who is Ana Lopez Marco from Barts again, and she's had a busy day today, and she's going to talk to us about the fate of acute aortic syndromes during the COVID-19 pandemic, and this is a UK multi-centre study.
Hello, ladies and gentlemen. It is a real pleasure to be here presenting on behalf of the UK Aortic Surgery Group our results of the COVID UK aorta multi-center study, in particular the fate of acute aortic syndromes. As you all know, the COVID pandemic has caused a very big restructuring of healthcare system, with elective surgeries put on hold in order to protect emergency activity. On the other hand, patients with acute aortic syndrome have a devastating natural history with incremental risk of mortality by the hour. We created a UK multi-center service evaluation study with the idea to assess access to emergency treatment, logistical limitation, and clinical outcomes of patients presenting with acute aortic syndromes to the participating centers during the first months of the pandemic in the UK. We recruited 19 centers, which represent 66% of the whole cardiothoracic units, and the centers are depicted on the UK map on the right-hand side. We recruited 88 patients during this period, the majority of them being type A aortic dissections, although we also have type B and aortic intramural hematomas and penetrating ulcers in this study. 90% of the patients received emergency surgery and only 5 patients were turned down. The reasons for that were not necessarily COVID related, but most likely due to pre-existing conditions. Other 3 patients died during transfer to the unit or during anesthetic induction, and the remaining patient was managed conservatively. Postoperative complications depicted on this table are fairly equivalent to pre-pandemic times, and perhaps we should highlight just 25% of in-hospital mortality, which is still acceptable, although in the high side of previous reports. The COVID screening recommended was not necessarily awaited in cases presenting with acute aortic syndromes. These cases were carried on with universal PPE measures. And despite that, only 5 patients tested positive in the postoperative period. Out of them, only 1 required prolonged ventilation, but there was no COVID-related mortality. We saw a significant temporal variation with the number of cases presenting to hospital dramatically reducing and almost disappearing in the first week after the lockdown started. And we explain this by the fear and anxiety of the population to go to A&E. Number of cases were increasing exponentially the following weeks to reach a plateau in April. In terms of regional variation, when comparing to pre-pandemic times, we have seen the majority of centers have maintained the same activity as previous year, apart from London, where 2 centers concentrated all the referrals for the region as were designated as COVID-free areas. So in conclusion, the service provision for acute aortic syndrome was maintained during the early months of the pandemic in the UK. We observe a very low risk of, a very low rate of surgical turndown and COVID-related complications. And with appropriate precautions, emergency surgery can be performed in these patients, achieving good outcomes. Many thanks for your attention. And if you want to have a bit more of detail, please refer to the 2 publications of this topic. Thank you very much.
Thank you, Anna. That was an excellent presentation. And we do have a question from the audience. What were your criteria for selecting the centres to be involved in your study?
So basically, this was an open invitation to all the cardiothoracic units in the UK, and they were the ones who decided whether they wanted to participate or not. Some of them were quite keen to enroll in the study, but due to the reduced numbers during this pandemic, they couldn't join us. And other units just didn't have the resources to do the data collection. But overall, we managed to recruit 60% of the UK representation, which is quite good.
Okay, yes. I don't think we have any more questions from the audience. Do you get a handle at all on sort of how many patients were perhaps not getting referred? It's difficult, isn't it? Because I think there's a huge amount of dissection patients that don't get referred anyway or don't make it to us. Do you think that changed during COVID?
I think absolutely, because what we saw on the first week after the UK went into lockdown for the first time is that actually that week there were close to 0 referrals. And we just assumed that it was because of all the chaos and the patients were just too scared to go to A&E, and perhaps obviously we are not accountable for all the deaths that happen at home.
No, I think you're right. I think there were probably quite a lot of people that didn't make it to us during the whole course of the pandemic. Did you experience that in the US as well, Dr. Chen?
We did, and not only did we notice that there were less patients coming to us, the ones that eventually decided to come to the hospital had been sitting on several days of symptoms and presented in worse, hemodynamic and cardiovascular conditions, more shock, tamponade, rupture, things of that nature. So it was quite unfortunate, because even in the emergency rooms here, they were some of the safest places to be, despite what the general public opinion was. So.
Yes, I think that's had a big impact, actually. Right. Yes.
So, great presentation, though.
Thank you very much, Dr.
Thank you, Anna. That was great. Thank you. Okay, I think we'll move on to the next presentation. So this is Azhar Hussain, who's going to talk to us about type A aortic dissection surgery performed by specialist aortic surgeons and the impact on short and long-term outcomes.
Hello, my name is Azar, and I'm an ST6 trainee in London, and I'll be presenting our outcomes on Type A aortic dissection, surgery performed by specialist aortic surgeons, and the impact on short and long-term outcomes. Aortic dissections are, of course, associated with a significant perioperative mortality, and they range from between 16 and 28%. The mortality within the first 24 hours is reported to be about 1 to 2% per hour. The relationship between surgical volume and outcomes has already been demonstrated across other specialties, and results from a North America database with 25,000 patients suggested that mortality in aortic dissection patients was significantly related to surgeon volume. A more recent study in the United Kingdom in Liverpool demonstrated that a dedicated dissection service staffed by experienced aortic surgeons resulted in improved short-term and long-term outcomes. Standard ascending aortic repairs are being replaced with more aggressive preventative repair strategies, and this involves both the aortic root and the aortic arch. As such, there has been a growing emphasis in establishing aortic specialist centers, dedicating to managing these patients in a timely fashion. We aim to evaluate perioperative and long-term outcomes associated with surgery by aortic specialist surgeons. We conducted a retrospective review on all patients who underwent emergency surgery between 2005 and 2020 at King's Hospital, and patients were divided into two groups: those who were operated on by a specialist aortic surgeon and those who were operated on by a general cardiac surgeon. We defined an aortic specialist as a surgeon that performed more than 30 aortic procedures, including surgery on the aortic root, the ascending aorta, the arch, and the descending aorta annually during the last 3 years. There were 3 specialist aortic surgeons and 3 general cardiac surgeons at our institution during the period of this study. The study population consisted of 232 patients who underwent emergency surgery. 186 were operated on by an aortic specialist and 46 by a non-aortic specialist. The patients were generally comparable in terms of mechanical ventilation, cardiogenic shock, and the use of inotropes preoperatively. The aortic specialist patients more frequently had a history of MI and PCI. The operative managements, the SAS group performed significantly more procedures that involved replacing the aortic root, 43% versus 17.3%, and only the specialist aortic group performed David and frozen elephant trunk procedures in the cohort. The aortic specialists had significantly shorter aortic cross-clamp times, as well as shorter bypass and a lower circulatory arrest time. Post-operative outcomes. The specialist aortic surgical group had significantly less post-operative bleeding. The requirement for renal filtration post-operatively was significantly less in the specialist aortic group, and this remains statistically significant even after propensity matching. Post-operative hospital length of stay was similar between both groups. Post-operative rates of stroke, AF, and I2 length of stay were comparable between both groups. The mortality rate was lower in the aortic specialist group, 10% versus 26% in the unadjusted outcomes, and was still significant when propensity matched. Long-term mortality follow-up over a period of 14 years showed a significant advantage in the aortic specialist group, 26% versus 52%, and this remains statistically significant even after propensity matching. These are our Kaplan-Meier survival curves. On the left is the short-term survival curves, and on the right is the long-term survival curves, showing the significant advantage with an aortic specialist. Our study is limited by its sample size and our single center experience. It was a retrospective study which has its own inherent flaws. Other potentially relevant factors such as improvements in anesthesia, perfusion techniques, including antegrade cerebral perfusion techniques, theatre equipment over the study time period were difficult to account for. In conclusion, patients with an acute aortic dissection, surgery performed by an aortic specialist results in improved short and long-term outcomes. More complex procedures were performed by aortic specialists, and aortic specialists replaced more of the dissected aorta, which may in part explain the improved long-term survival in this cohort. This study adds further support in establishing a specialist aortic surgical service in cardiac centers. Thank you. I think you're on mute. Sorry.
Can you hear me now?
I can hear you now, yes.
Sorry about that. Thank you for that excellent presentation. As you said, we previously demonstrated this difference between specialist aortic surgeons and outcomes with dissection. What is the current situation at your hospital? Are you part of the established, one of the established aortic rotors?
Yes, so King's is part of the South London Aortic Dissection Network, so we rotate between King's and Tommy's, the dissection service. And there are dedicated dissection consultants at our hospital and as well as at Tommy's hospital as well.
But so some of this data was historical. So do you think that that things have improved further since the establishment of the rota, and presumably those cardiac surgeons, non-aortic surgeons, are now no longer participating? Is that correct?
That's correct. Yeah. So the non-cardiac surgeons no longer participate in the aortic service, and the mortality has gone down to 14% from 24%. Across the South London network as well. So we've noticed this improvement since the network has been established, and we haven't done a subset analysis, but I think we hope to do that within the next couple of years.
Okay. I think one of the things that we've kind of possibly noticed is that since we've had a subspecialist service, the mortality does still fluctuate, and I wonder if subspecialist teams are perhaps getting more complex cases from other centres around the country, and also perhaps we're more likely to operate on higher risk patients that perhaps would be turned down from other centres. I don't know if you've seen that at all.
Absolutely, and I've seen it at both King's Hospital and at Bart's Hospital, where we take on much more complicated cases, and we take it from further afield, from outside our normal referring hospitals. So yes, absolutely.
That was a great talk, and really congratulations to your institution for allowing a study like that to be go forward, knowing the political implications of that with the non-aortic specialists. Did you study the difference in anatomy between the aortic specialists and the cardiac surgeons with respect to aortic root replacement, arch replacement? Were there differences that led to a higher incidence of root replacement in the aortic specialists, or was it just something that perhaps they're borderline cases that maybe a non-specialist would not want to tackle, but a dedicated surgeon would? Or I mean,
I think we did look at the anatomy. So I think in the presentation we did detail the fact that the specialist aortic surgeons did perform more aggressive aortic surgery. The reasons behind it we didn't get to, but the specialist surgeons would more frequently perform a root procedure or involve the arch, even prophylactically. But we didn't actually look at the reasons why the non-aortic surgeons didn't do that. And that would be interesting.
Now, we actually have quite a few questions on the chat here. This has sparked quite a lot of discussion. So this is good. Thank you, everybody. So first question, great presentation. What do we need to do in the UK to ensure all patients benefit from being treated by aortic specialists?
That's a difficult question to answer, but I think there is a growing perception within the UK now that, across America as well, that all aortic surgery should be centralized, and there is a growing move towards that. We've already done it in South London, and there's already a dedicated centre in Liverpool. So I think over the next 5 to 10 years, all of the new cardiac consultant jobs that are coming out now are either an aortic specialist job or a mitral job, and there is a growing. The role of a general cardiac surgeon is probably no longer going to be advertised anymore. It's going to be specialist aortic surgeon or a specialist mitral surgeon. So I think the next cohort, the next generation of consultants will be an aortic specialist surgeon.
And we have another question here from Professor U, who we seem to have lost. But anyway, Ong, you're obviously out there somewhere, saying, did you see influence of personal dissection volume over total elective aortic volume? I think that's a really good question.
Sorry, I didn't get that, sorry.
So did you see influence of personal dissection volume? In other words, the number of dissection patients an individual surgeon did over the total elective volume? So in other words, does the number of dissections you do matter if you do elective surgery? Or is it the fact that you're doing elective aortic surgery? Do you think there's were you able to look at that at all?
No, we didn't look at that as much. No, I don't think we were able to distinguish between the two, not yet. But we will do next.
Okay, and I think there's one other question as well. In difference in clinical presentation between the two groups. So did you? Oh, here we go. Yeah, sorry. Did you see a difference between the two groups in terms of malperfusion? So any clinical differences?
No. So in terms of malperfusion, no. The rates of malperfusion preoperatively were the same in both cohorts.
Okay, thank you. Okay, that's great. Thank you very much. I think probably in the interest of time we should move on, but thank you for that. That was generated quite a bit of discussion. That's great. And so our next speaker is Genti Jakaz. Sorry if I said that wrong. And this is going to be a comparison of antegrade and retrograde cannulation strategies on renal function in aortic dissection patients.
Comparison of antegrade and retrograde cannulation strategies in renal function in aortic dissection patients. Acute type aortic dissection is a life-threatening condition requiring emergency surgery. Different cannulation strategies exist to establish capillary bypass for aortic surgery. Consensus regarding the optimal cannulation strategy is still lacking. We report our experience comparing antegrade aortic cannulation versus retrograde cannulation in aortic dissection patients and its impact on mortality, renal dysfunction, infection, and stroke. A single-center retrospective study review of 230 patients who underwent surgery for type A aortic dissection was conducted between 2005 and 2020. The cohort was divided in those who had antegrade cannulation, we call them Group A, 165 patients, and those who had retrograde cannulation, we call them Group B, 65 patients. Statistical comparison was done using regression modeling. Kaplan-Meier comparison was undertaken using Stata 14. The table on the left, apologies for being so crowded, shows all the demographics and preoperative medical findings that we had on these patients, and we looked at the differences.
Okay.
The main difference was that the Group A patients were a bit older than Group B patients, 63 versus 58 the median age. The history of renal failure was more frequent in Group B patients in comparison to the Group A, 14 to 6%. The rest of the data is preoperative mechanical ventilation, cardiac shock, previous history of stroke, the use of anatropes were comparable between both groups. And the intraoperative management is shown in the table on the left. The main difference in both groups A and B is in Group A, the more complex procedures were performed as David's, frozen elephant trunk. Group A also had shorter cross-clamp times, shorter bypass times, and the shorter circular arrest times. One thing I'd like to show you in this, it was this graph, which basically is a graph showing the creatinine level on the days in the 6 consecutive postoperative days. It's quite interesting to finding that we found that the increase of the creatinine in Group B was much more significant, specifically 48 hours after the surgery was more significant in the Group B rather than Group A. The postoperative outcomes are shown in the table on the left. We found that the Group A mortality initially was found to be lower in compared to Group B. However, in further analysis, so there was no difference between both groups. Prolonged ventilation was less in the antegrade group, which remained significant even after the risk adjustment. Postoperative hospital length of stay rates of stroke, atrial fibrillation, ICU, length of stay, and other potential complications were similar between both groups. The table on the left shows the effect size of variables on immediate postoperative renal function. We did this based on the finding that I showed in the previous graph, and we found that the postoperative renal impairment had the largest effect size on postoperative renal dysfunction, pre-operative renal impairment. Cannulation strategy had a similar effect on postoperative renal failure as pre-operative cardiac shock. Our study is limited by small sample size in our single center experience. It was a retrospective study, which in the zone has inherent flows. Our unit comprised of surgeons with varying degrees of aortic experience. Experienced surgeons were more likely to use an antegrade approach, whereas others may have preferred more conventional approach as a femoral. Furthermore, other potential relevant factors such as improvement in anesthesia, perfusion techniques, and theater equipment over the study period were difficult to account for. And as conclusion, in our study, antegrade cannulation has shown to have less renal impairment to retrograde in postoperative patients. The effect size of renal impairment in type A aortic dissection is similar to cardiac shock. Our study found no significant difference on incidence of stroke mortality between both groups. Of course, further studies are required to recommend antegrade cannulation as a standard approach in patients with type aortic dissection. Thank you.
Well, thank you. I believe Dr. Hussain, you're back again with us to answer questions.
Dentist sends his apologies, he was not available.
Thank you. Oh, thank you. We do have one question from the audience.
Yep.
So what about for patients that had normal preoperative kidney function? Was there any difference between the groups?
There's a normal preoperative kidney function.
Yes.
So we didn't do a subset analysis of that. We just looked at the cohort of patients who had antegrade versus the cohort of patients who had retrograde. So we didn't do a sub-analysis of that.
Okay. Okay, thank you.
And Daza, do you think it is because of some degree of malperfusion from the retrograde cannulation?
Absolutely. So that was our thinking method when we were doing the analysis.
Yeah, even though we may have a kind of subclinical kind of malperfusion going on during the case.
Absolutely.
The great kind of the re-establishment of the circulation. Probably that might be the reason.
Absolutely, and that's what we think. The initial post-operative renal impairment was because of the retrograde flow from retrograde cannula that might be causing this impairment. I mean, we haven't done a longer-term study on the renal impact, on the renal function impact, but I think an immediate kidney hit will have some long-term effects, especially in terms of the hospital length of stay and the resources required in the early post-operative period.
Okay, thank you. Thank you, Dr. Hussain.
Thank you.
Our next speaker is one of my colleagues from Liverpool, Dr. Riaz Akhtar. He's actually an engineer, if I'm not mistaken, and he's going to talk to us about the chronic dissection flap exhibits increased stiffness and reduced time-dependent deformability.
Hello, my name is Dr. Riaz Akhtar from the University of Liverpool, and I'll be talking about our study which examines biomechanics and biochemistry of chronic dissected tissues. Little is known about how the mechanical properties and the associated biochemical properties of chronic dissected tissues change over time. In this study, we examine the time-dependent properties and also the tissue stiffness of the dissection flap, the true lumen outer wall, and the false lumen outer wall, relate these with tissue biochemistry and histology, and correlate these properties with that time period from the initial dissection to operation for a chronic dissected aneurysm. All of our patients underwent elective surgery at Liverpool Heart and Chest Hospital. We had a diverse group of 16 patients, 4 of which had Marfan syndrome, and all had a preoperative aortic diameter which is greater than 6 centimeters. The experimental approach we've taken is utilizing a ball indentation test, which is applied to thin sections of the tissue, and this allows us to obtain the tissue stiffness and also to determine how the tissue responds to a fixed load which is applied via the ball to the tissue over a long period of time, so over 5 hours in our experiments. These mechanical measurements are correlated with collagen, elastin, and glycosaminoglycan measurements, as well as with elastin organization via histology. These images show what is captured with a long focal distance camera with this ball indentation technique. You can see here how the ball deforms the tissue instantaneously for the flap, the true lumen, and the false lumen, and also over 5 hours. So over 300 minutes, we can see how the tissue responds to a fixed load over time. It's clear from these images that the false lumen exhibits the greatest deformation relative to the flap, and you can see that here in this graph on the right-hand side. So the central deformation, which is captured via the images, is highest in the false lumen and lowest in the flap tissue. And similarly, the elastic modulus follows a trend which is inverse to that seen with the central deformation. So the flap tissue is the one which is stiffest, and the false lumen is the most compliant. And you can see that the Marfan syndrome patients fit within these box and whisker plots, so they do not appear as outliers. In terms of the biochemistry, what we find is that the flap tissue has the highest elastin, but is quite variable, and the highest GAGs and the lowest collagen to elastin ratio. And the false lumen has the highest collagen to elastin ratio. We can see from these images as well that the flap has quite a lot of intact elastin organized in long straight segments, whereas the false lumen has elastin which is much more scarce and also more fragmented. With the interval of index event to operation, that time period of dissection to operation, we find that there's a positive correlation with the tissue stiffness, the elastic modulus, with the flap, and the negative correlation with the central deformation. So with time, as patients live with this dissection, the flap tissue is becoming stiffer and it's becoming less compliant, less able to move. And no such correlations were seen for the other tissues that were studied. So in summary, we found that the flap is a stiff tissue and has less time-dependent deformation relative to the false lumen and the true lumen outer wall. And this could be correlated with the biochemical properties and also the histology. And only the flap correlated with that time period from the initial dissection to the elective surgery. And the most interesting finding is that regardless of the initial etiology of the dissection, all of these tissues behave in the same way, and that initial etiology has no role to play in the dynamics of the tissue. We can say that the flap is a dynamic tissue which is responding to the local hemodynamic environment. Thank you for your attention, and here are our acknowledgements.
Excellent work, Riyadh. Yes, excellent. And then I'm familiar with this work, obviously. So, and the one thing that I'm kind of clear, very, very kind of interesting is to see that we know when that we treat the patient with the chronic dissection, and then when, especially using endovascular kind of technology, it's quite interesting useful for us to know when the kind of the pliability of this the septum get to the point of the stent not allowing the stent to be expanded to the full extent. So I wonder kind of whether your information would then help us to see that time frame of where we can then probably kind of say up to 2 years, up to 5 years, where we can actually use endovascular stent graft to expand it, and that against your kind of becoming stiff kind of septum.
I certainly hope so. I hope that this work will lead to that. I guess the limitation currently is that we have relatively small numbers, but then of those 16 or so patients, what was interesting, as I highlighted at the end, is that irrespective of whether they were Marfan, ascending, descending, male or female, they all fit the similar trend. So it does seem, if we build up a bigger database, we will be able to provide information which will be directly relevant to the surgical interventions that you're talking about.
Okay, thank you, Riaz. That was excellent. And we look forward to hearing more in the future when we've got more data. Thank you very much. I don't think we have any questions from the audience on that. I think you've blinded them with science as usual there, Riaz. Thanks very much. So we'll move on to our next speaker, who is Philip Hartley, who's going to talk to us about the diagnosis and management of acute type A aortic dissection in emergency departments, updated results of a UK national survey.
Good afternoon. My name is Philip Hartley. I'm an ST2 cardiothoracic trainee in London, and I'm here today to present a piece of work I did last year on the management and referral of patients with acute type A aortic dissection from UK A&E departments to cardiothoracic centres. I did this piece of work together with Yusuf Salmasi and Thanos Athanasi. So just a little bit of background. There are about 3,000 type A aortic dissections each year in the UK, and 20% of these patients will die before reaching any hospital, and 50% of patients will die before reaching a cardiothoracic centre. So clearly there is a potential for improvement in this time-critical diagnosis, and we're interested in trying to maximise the number of patients who have the opportunity to have a definitive management of their dissection at a cardiothoracic centre. And really, we know that the main cause of operative delay is delay in the diagnosis of type A dissection. And it's not just the delays in the diagnosis of type A dissection, it's also the potential for mismanagement causing further harm to these patients. Hansen et al. Showed in a paper a few years ago that the most common misdiagnosis in cases of aortic dissection is acute coronary syndrome. And further, that if these patients are managed with antiplatelets or thrombolytics, they're exposed to additional risk of bleeding and short-term mortality. So our study was a survey-based study that was sent to emergency medicine consultants across the UK, and it focused on 3 main areas. The first was the management of chest pain in UK A&E departments. Secondly, the investigation of chest pain. And thirdly, referral pathways to cardiothoracic surgery. So I'm not going to go through the responses to each individual question in the survey, but I'm hoping to highlight some key take-home messages from our results. So we had 132 responses from emergency medicine consultants from 54 NHS trusts, and you can see from the pie chart on the right of the slide that there was a good geographical variation in where the respondents were based. So we hope that our results reflect national practice across the UK. And 20% of respondents were from emergency departments based in tertiary cardiothoracic centres. So one of the key questions we asked was whether, in the setting of acute chest pain and ischemic changes on ECG, whether emergency medical consultants felt this was sufficient to make a diagnosis of acute coronary syndrome. And over 100 of the 132 respondents felt indeed this was sufficient to make the diagnosis. And clearly these features, although commonly associated with acute coronary syndrome, they may also be associated with rarer conditions such as aortic dissection. And then we went on to ask about whether in the same situation, so that's acute chest pain and ischemic changes on the ECG, whether respondents felt this was sufficient to initiate management of acute coronary syndrome, including antiplatelets and thrombolytics. And we found that over half, so over 70 of the 132 respondents felt indeed, yes, this was sufficient to initiate the antiplatelet or thrombolytic therapy for the treatment of acute coronary syndrome. And clearly this has the potential to expose patients who have had an aortic dissection not only to delay, but also to potential harm from these agents. However, in cases where the patient additionally had unilateral pulse deficits or features of stroke, the proportion of respondents who would then commit to antiplatelet or thrombolytic therapy fell to 10.4% and 8% respectively. So clearly these features that may be associated with aortic dissection are very much protective from mismanagement or a delay in diagnosis. Whereas simply acute chest pain and ischemic change in ECG, these patients are very much more exposed to delays and mismanagement. In terms of investigation of chest pain, the CT chest is clearly the most important investigation required to make the diagnosis for aortic dissection. And we found that over 40 respondents would never request a CT chest in the setting of elevated cardiac enzymes and acute chest pain, which is not only associated with acute coronary syndrome, but also many cases of aortic dissection. So the take-home messages from the study were really that the patients with aortic dissection and features of acute coronary syndrome are at particular risk of misdiagnosis or inappropriate management in any departments. And clearly this is a difficult diagnosis for emergency departments to make because of the rarity of the condition compared to acute coronary syndrome and other related conditions. But we hope through campaigns such as the Think Aorta campaign led by the Royal College of Emergency Medicine and SCTS, the profile of aortic dissection and the consideration of CT chest will be raised in UK A&E departments. Thank you for your attention. I'll be delighted to take any questions.
Thank you, Mr. Hartley. That was an excellent presentation. What sort of interventions do you think we could employ subsequent to the Think Aorta campaign to try and improve diagnosis amongst A&E physicians?
I think that's a really difficult question to answer. I think it is obviously a lot about awareness and an appreciation of how difficult the job is for emergency medicine physicians. And obviously they're seeing so many patients with chest pain and they really are looking for that needle in a haystack. So I remember when I was an F2 working in St Mary's, and we had the Think Aorta posters on the wall encouraging people to think about CT chests. So really I think it is awareness in terms of kind of national strategies for that. I guess it's kind of keeping the momentum going with campaigns like the Think Aorta campaign. But I think having a good understanding and appreciation of how difficult the job is for most emergency physicians is kind of the way to get those physicians on board with that message.
I think we've noticed, I've certainly done quite a few talks locally to various different A&E departments and regional groups, and I think we've noticed a difference. And I've even actually emailed individual A&E physicians when diagnoses have been missed and patients have come later and so on. And I think I've started to notice a difference. So I think we have to keep plugging away at it.
That's great. Yeah. I'm sure they really appreciate getting that individual feedback and about their patients.
Ed, and in the US, you have a scenario where you have kind of the paramedics and the ambulance who would make the diagnosis and can divert the kind of the aortic dissection patient directly to you.
There's a little static on the line, so I want to make sure you're asking if the paramedics can make a diagnosis and then shove it to a center. Typically, I think the paramedics often take patients. I don't think they can make a diagnosis per se unless they're really clinically astute. They take patients often to the first emergency room or the closest ones available. Sometimes patients can make a request as to where they want to go. And if you happen to land in a center of expertise, then you're in good fortune. But, you know, there's no system that's put in place that where one can be identified as a potential aortic dissection patient and then get routed to the appropriate center. So they don't have that. We don't have that type of system in place. And so you feel lucky oftentimes if one shows up in your emergency room where we work, for instance, because, you know, it's easy. But a lot of times we're very small community hospitals with smaller centers that either don't have cardiac surgery services or surgeons that don't perform those very often and may not be comfortable with. But I would say more because they recognize that these are, you know, potentially lucrative cases. Some of those things, these cases are being done more frequently in hospitals that do cardiac surgery in general, even without aortic expertise.
We do have a couple of comments on the and questions on the chat. We've got a dissection survivor actually who said, "Do you think that the Think Aorta campaign has had any impact so far? Are any studies being undertaken?"
I don't actually know if there's any kind of auditing of the Think Aorta campaign, but certainly from my own experience of being a junior doctor in the A&E department, the Think Aorta campaign was definitely visible, and it was something that emergency medicine consultants did talk about and talk to their juniors about. So from my own personal experience, I would say yes, but in terms of kind of national auditing of the campaign, I don't have any information about that.
I think we will be looking at that. Ong will probably know more about the research that is going on. I think it's intimately intertwined with other initiatives as well. I think too, there's lots of initiatives around the country in terms of subspecialisation, which we've already talked about a little bit. And so it will never be possible to kind of take those, you know, separate those factors. And obviously COVID has had a big impact as well. But I think we will have data in the coming years. I don't know if you want to say more about that, Ong.
I think it's a multi-pronged approach, isn't it? Because are we kind of educating the kind of public as well as educating the kind of the A&E departments, and the emergency medicine is the first kind of important protocol. But we noticed, the reason I asked for the paramedics is that when the heart attack moves on to the acute ACS pathway, and that from the starting measure from the needle and the aortic balloon, all these target changes, and that's into the the outcome. I think personally, I think that eventually we get to the point we get to bypass the emergency room and make the kind of some near-based assessment to get the high probability to get them the right ECA and the right go to the field rather than the kind of patient for in that kind of in to attain the kind of outcome basically, but it will be already quite a few years ago. I think there are now a brown pepper at the moment already the market is super.
Okay, I think in the interest of time, we should move on. Thank you, Dr. Hartley. Our next presentation is the evaluation of time taken between aortic dissection presentation to the emergency department and definitive surgical intervention, and it's Dr. Nzenwa.
Good afternoon, everyone. My name is Ikem Nzenwa, and I'm a medical student from the University of Liverpool. Today, I'll be presenting our abstract on behalf of Professor Field and his team. The risk of death increases by up to 3% every hour in the first 24 hours following an aortic dissection presentation. Even though surgical advancements have greatly improved AD outcomes, we are still seeing high mortality rates. We identified 3 factors contributing to this trend. First, a delay in diagnosis. Second, a suboptimal initial management. And third, a delay in the transfer from the A&E to the theaters. The rarity of this condition contributes to the delayed diagnosis, and this inspired the Think Aorta campaign that encouraged doctors to consider aortic dissections as one of their differentials for non-specific cardiac symptoms. Professor Mark Field developed the key quality indicators, which are a regional gold standard for managing aortic dissection in patients being referred through Lantas. The goal is to get the patient from symptom presentation to the operating theaters within 6 hours. This could be achieved by diagnosing the patient within 4 hours of arriving at the A&E and getting them to a tertiary cardiac center and the theater within a further 2 hours. We aim to evaluate the time taken between presenting at A&E and receiving surgery to identify areas where delays can be reduced. We also wanted to assess the impact of the Think Aorta campaign. For each patient, we identified the diagnostic time, the transfer time, and the on-site intervention time. Here are some of our results. 43 patients were treated for AD at LHCH between January 2018 and November 2019. We found that 2 hours was the most common time taken for patients to receive a CT scan. In line with our KQIs, only about 60% of patients were diagnosed in the recommended time. Here in figure 2, we can see that 3 hours was the most common time taken from the CT scan to arrival at LHCH. Only 11 patients arrived at LHCH within 2 hours. Operating within 3 hours of arriving at LHCH was the most common time taken, with only 7 patients arriving at theater within 2 hours. So here we have summarized our findings. The diagnostic time was the shortest stage in the pathway. Interestingly, the longest stage was the time taken between arriving at LHCH and undergoing surgery. However, the diagnostic time was the stage most vulnerable to long delays, with 1 patient getting a diagnosis after 120 hours. The orange dotted line represents the medians from a previous audit done at LHCH. At a glance, we can see that the results show that we are quicker at ordering CTs and transferring patients, but we are still slower when it comes to operating. Overall, we can see that the median time from admission to operation has decreased since introducing the Think Aorta campaign. So who's most at risk of delay? A multinational study conducted in 2011 found that patients transferred from non-tertiary hospitals and patients with atypical symptoms were most at risk of delay during the diagnostic stage. They also found that from the diagnosis to surgery stage, non-white patients, patients with a previous cardiac surgery history, and patients with a prolonged time from presentation to diagnosis were most at risk of delay. In conclusion, the average of 12 hours from presentation to surgery increases the risk of death. The preoperative stages may offer the best opportunities for review of interventions to expedite access to definitive surgery. We can continue to improve the education and raise awareness of frontline medical staff about AD and its initial management. The Bristol Royal Infirmary increased their CT scanning for potential patients from 20 scans in 2009 to 300 scans annually, and are now detecting these AD cases once every 6 to 8 weeks. So AD may not be as rare as we thought. Finally, a multidisciplinary regional protocol, which includes specialized aortic dissection teams, will not only decrease delays in diagnosis and treatment, but also standardize the way AD is managed. Thank you very much.
I think you mute, Debbie.
Sorry, did it again. Sorry, thank you for that excellent presentation. We do have a question from the audience. I think this is the pertinent question, actually. So, do you take the patient directly to theatre or to ITU first?
I'm just this will be of correction from the start. I'm a medical student.
I know. Don't worry, I can answer that for you. Sorry. So most of the time, generally, patients still go to ITU first. And I think unless the only time when we haven't done that actually is when we don't have a bed and we know we've got a young patient coming, and we occasionally do take them straight to theatre. But generally speaking, we still take them to ITU first, and I think we've still got work to do on our end of the on our side of it. What about can I ask Ong and Ed what your thoughts are on that?
And you know that Debbie, we changed the kind of return protocol. So now all the patients, then once they accept it and en route, and when they come in ambulance, we already admit the patient with the NHS number. And then so they go straight to theatre, and then we start the case with emergency blood available, but the cross-matched blood goes in as the kind of patient arrives. So by the time we're ready to go on bypass, the cross-matched blood will be available. So by doing that, at least we can cut down a couple of hours of hanging around the ICU and doing paperwork and usual stuff. We've seen a couple of 2-3 patients being ruptured on ITU and then run into having to massage and then get the bad outcome. So since when we changed that. You're mute as well, Ed.
Thanks, thanks, Debbie. Great presentation too, sir. It depends on hospital. A lot of times we also send patients to the ICU or ITU, and we agree that's a very vulnerable period. So we wanted them to go straight to the OR, at least the pre-op holding area. I think, as Long said, I've even had patients that have collapsed when getting the consent in the ICU. But really, a patient that arrests with a type A, you won't get them back unless they're in the operating theater, operating room. So in any event, there are a lot of little things that can be done that can really help the outcome of some of these patients.
And one thing I noticed in your presentation, it is about the time delay from the kind of the diagnosis after CT scan in the A&E department to the transfer to Liverpool Heart and Chest. It was about 2 to 3 hours minimum, isn't it? So, and have you actually looked at the kind of the adjusted with the distance to travel? I know that some patients came from the North Wales, and some patients from Cheshire, some are from the local kind of the Liverpool St. Helen Hospital. So if you look at the distance to adjust it, that would be interesting to see the.
Well, that's a really good point. We didn't take into account the distance we had some patients come from Isle of Man as well. And as you can imagine, being referred from such a distance as compared to being referred from like one of our local hospitals, I'm sure that definitely have an impact. But no, we didn't take that into account.
Because I remember that one patient flew in from the Aberdeen, arrived us in about 3 hours, but the patient North Wales arrived much later.
Sometimes even the local patients can arrive later than the ones that get flown in. Yeah, it's still a big issue. I think we should move on. I think we're running a little bit late, but thank you for all the questions, though. We've got an excellent discussion, and it's on a similar sort of theme, actually. Another presentation from one of our trainees, Amir Harki, who's going to talk to us now about outcomes of type A dissection repair during in-hours and out-of-hours. Again, this is from Liverpool.
Good afternoon, everyone. My name is Amir Harki, and I'm an ST4 in cardiac surgery at Liverpool Heart and Chest Hospital. I would like to thank the organizing committee for giving me the opportunity to present our study today. I will be presenting our experience and outcomes in acute type A aortic dissection patients that were operated on during in-hours versus out-of-hours over the period of 21 years, divided into 2 significant cohorts of pre-existence of specified aortic rota and after the implementation of the specialized aortic rota. As we all know that acute type aortic dissection patients are high-risk patients, and the pathology by itself is a life-threatening emergency and requires immediate surgical attention once it is diagnosed. Open surgical repair should be offered as the gold standard treatment where it's feasible. In the last decade, several centers internationally have published that operating in specialized aortic centers, who are high volume centers, gives better outcomes in such high-risk patients. Currently, there are a wide range of literature evidence, and there is recently many reports discussing their outcomes. In the latest study by Gasser et al., in their cohort of 319 patients of acute type A aortic dissection, they reported no differences in mortality between those patients who were operated on during daytime or out of hours during the weekend. Similar outcomes were reported by another study that included 164 patients. However, not many papers has compared the outcomes of pre-rota versus post-specialized rota. In our study, we have concluded that presence of a dissection rota can improve the mortality significantly during in-hours versus out-of-hours. Finally, our recent meta-analysis shows that outcomes in such high-risk cohort does not differ when it's operated on clinical emergency basis. In our study, we sought to report our experience before and after the establishment of the dissection rota, comparing the clinical outcomes. A retrospective analysis was done of all patients that underwent repair of acute type A dissection between 1998 to 2019. As I have discussed earlier, so our cohort were divided into two main groups: a pre-rota, which was composed of 80 patients between October 1998 to September 2007, and then a specialized aortic rota between 2007 and December 2019. This entailed 206 patients. In our results, we report no significant differences in the operative times or the rate of total arch replacement between both cohorts. This was also similar when we compared the data of pre-dissection rota and post-dissection rota. However, there were a high number of aortic root replacement and slightly shorter DHA time in patients who were operated in out of hours. Furthermore, the outcomes were reported not to be different during in hours versus out of hours in terms of mortality and major comorbidities, neither during pre-rota establishment nor during post-rota establishment. However, as we can see that the mortality from the pre-rota was around 30%, yet this significantly improved with the establishment of the specialized rota in our unit. So in conclusion, we report that there is no difference in outcomes in operating on such high-risk patients, and our results are in line with current reported literature. Therefore, treatment of acute type aortic dissection should be decided on clinical emergency in such patients. Thank you.
Thank you, Amir. I'd like to ask, I know that we still do operate in the night. What about Ong and Ed? What are your thoughts about that? Do you still operate in the night on type A dissections, or do you wait till the morning? You know, for those ones that come in at sort of 3, 4 in the morning.
Debbie, I think that we in general try to just operate right away, knowing the time sensitive impact on mortality. I think for one case where we may wait till the next morning is if a type A, if it's an IMH, we might just sit on that one till elective hours. But typically we try to go straight to surgery when we have a patient like this. Yeah.
Yeah, the same, Debbie. I think even though there was a time that because the paper from Hassan Safi and group saying that it is safe to stabilize and do the operation in the morning, but I think our kind of experience across the board is there's increased risk of rupture and dying while waiting. So I think we tend to take most of the patients to theater straight away. But there will be a group of patients with, say, previous coronary surgery, for instance, and a patient who are old that we want to assess a little bit more, or a patient with a malperfusion that we want to tackle something else, then maybe that we may delay it till kind of morning or maybe later in the day.
You know, I learned from Safi about delaying that, Ong, and we practiced that for a while. But I think, at least in the United States, the medical legal, it's a litigious society. So I think it's for us, it's, you know, you put yourself at those types of risks beyond the patient, the medical risk if you delay. So I think it's better just to operate immediately.
I agree totally. Yeah. One thing that I mean, when you look at the kind of series, I think I know I probably cannot partly because I was involved in that. So I think having a rota alone probably doesn't change. I'm not sure because I think probably the volume of the kind of surgeons who are operating and in the rota with the elective volume as well as emergency volume probably may affect it, I think. And do you know it's difficult to say that in the kind of your series, isn't it? Because Liverpool series essentially started with the aortic dissection rota with all the people who perform the aortic surgery rather than in the general rota. I think that may be different if you look at the kind of volume outcome relationship with the kind of the participant in the kind of or the dissection rota. I think that's probably something that to look at a bit more in detail, I think. And the day and night time is always difficult because but I'm night owl, so it doesn't matter.
I think, thank you, Amir. I think we probably should move on. We're getting told that we're running late, but thank you to everybody. We've got lots of questions that we haven't answered, but so I'm sorry about that. But I think in the interest of time, we will move on. So we're honoured to have Dr. Chen here with us today, who is now the Chief of Cardiovascular and Thoracic Surgery at Duke University, and he's going to talk to us, give us the keynote lecture, Cerebral and Spinal Cord Protection in Acute Aortic Arch Surgery. Thank you.
Hello. It's a privilege today for me to speak to you on cerebral and spinal cord protection in acute aortic arch surgery. These are distinctly different topics, and I'm going to cover them one at a time during this lecture. So cerebral protection is one aspect of the overall contemporary circulation management strategy used for open arch repair, along with myocardial protection and lower body perfusion. These three components constitute the necessary strategy needed for optimal patient outcomes. The key components of a contemporary cerebral protection strategy include the arterial cannulation site, the degree of systemic hypothermia employed, and adjunctive cerebral perfusion techniques. In the 1970s, the primary cannulation site was the femoral artery, and isolated deep hypothermia at 18 degrees Celsius was a primary mode of brain protection during arch reconstruction. But over the last 50 years, we now have a multitude of options for cannulation, including the ascending aorta, axillary artery, and ommate artery. And then in terms of brain protection, we still can use deep hypothermic circuit arrest, but moderate hypothermia has emerged as a safe option, along with both or either ACP, antegrade cerebral perfusion, or retrograde cerebral perfusion. This is the consensus by the ARCH study group on classifications of hypothermia. As you can see, there's 4 categories of hypothermia: profound hypothermia less than 14 degrees Celsius, deep from 14.1 to 20, moderate hypothermia, a broad range from 20.1 to 28 degrees Celsius, and mild 28.1 and higher. So how do we measure outcomes when we think about cerebral protection? Well, we measure operative mortality and the degree of cerebral injury. Cerebral injury can be further categorized into permanent neurologic dysfunction, which is focal strokes, coma, and often the result of atheroembolic disease and atheroembolic events. Temporary neurologic deficits are a result of global cerebral ischemia and result in seizures, non-focal neurologic deficits, confusion, delirium, and are often associated with negative brain imaging. So what is really the optimal strategy? In terms of protecting the brain in today's world, we've got deep hypothermic circuit arrest, moderate hypothermic circuit arrest, RCP, ACP, and integrated cerebral fusion can further be divided into unilateral and bilateral. So what is really the optimal therapy? So let's take a closer look at the data. So our current understanding of deep hypothermic circuit arrest comes from our colleagues at Yale and who have been long proponents of this technique. This is a recent publication examining a large number of patients over a 12-year period. The average time of DHCA was nearly 30 minutes, but ranged from 10 to 62 minutes. Over 3/4 of these patients had hemiarch reconstruction, but about 20% had a total arch replacement, operative mortality 2.9%, and the rate of stroke 2%. If you look at these graphs, the far left graph was the overall study population compared to the age and gender matched population. There was worse survival over a 10-year period, but if you teased out the dissection patients and only looked at elective first-time patients, ultimately their survival over a 10-year period was similar to that of an age and gender matched population. RCP can be used for prolonged circulatory arrest, as demonstrated in this paper from our colleagues at Cornell. Over a long period of time, RCP was conducted at 18 degrees Celsius. Almost 1,000 patients had circulatory arrest times less than 49 minutes, but 50 patients had circulatory arrest period of over 50 minutes. And when you compare the patients that had a 50-minute circulatory arrest time with those having less than 49 minutes, there was no significant difference in operative death or stroke, as evidenced by both permanent neurologic dysfunction, permanent stroke, or temporary neurologic dysfunction, TND. This curve shows that the overall patient population survival over a 6-year period and was about, over a 10-year period rather, was about 35% at 10 years and did not differ depending on the length of time of circulatory arrest at the time of your aortic arch reconstruction. ACP in the setting of moderate hypothermic circulatory arrest is safe, as demonstrated in this particular study from our colleagues from Germany, looking at almost 600 patients, about 2/3 of which were unilateral ACP, 1/3 bilateral ACP. Circulatory arrest carried out at 28.7 degrees, and about 2/3 again had hemiarch reconstruction, and about 40% had total arch replacement. The incidence of TND and permanent stroke did not differ whether you had unilateral or bilateral ACP. And if you look at the overall survival curve, survival was about 70% at 10 years. So how about unilateral versus bilateral ACP? Well, that was studied in this paper from China, and they looked at 200 patients, which included type A dissection patients, total arch replacement patients. About 40% had unilateral ACP and about 60% had bilateral ACP. And in that particular study, the 30-day mortality was trended toward being better in the bilateral ACP group, but that did not reach statistical significance. Furthermore, there was a small degree of paraplegia, but no difference in the, which was not different between the two groups, and no difference in the rate of stroke between bilateral ACP and unilateral ACP, nor was there a difference in the temporary neurologic dysfunction. So if you look at all the comparative studies, most of these comparisons are single institutional review changes over time. There are numerous number of these in the literature. These are limited by a retrospective nature, lack of control groups, lack of randomization, and differences in repair techniques and patient populations. Essentially, these studies have demonstrated equivalent outcomes in deep hypothermic stroke to rest and moderate hypothermic stroke to rest, but there's insufficient evidence thus far to determine superiority or non-inferiority. A randomized control study on a large scale has yet to be performed. And this is a paper that, this was just a summary paper published several years ago from Annals of Cardiothoracic Surgery, listing all the papers at the time that had been published on various methods of cerebral protection, neurologic protection in the literature. And as you can see, whether there was ACP, RCP, moderate hypothermia, deep hypothermia, there were very similar rates of operative mortality and similar rates of permanent stroke in the 0.9 to up to 12% range, but really in the single digit, more in the 4 to 8% range. T&D also had a variety, but essentially equivalent studies overall. So in terms of expert consensus, I think in general for hemiarch reconstruction involving circulatory arrest times of less than 30 minutes, DHCA alone, DHCA with RCP or MHCA with ACP there's no clear consensus, although there is expert consensus on recommending some adjunctive perfusion technique, either ACP or RCP, as part of your surgical strategy. For total arch operations, for those involving circulatory arrest times over 30 minutes, it can be done with DHCA, RCP, or MHCA, ACP. ACP is recommended, but there's no clear consensus between DHCA and MHCA in this based on the literature thus far. So in the current era, the optimal method, cerebral protection, remains debated. The challenges are that most studies have relied on clinical neurologic endpoints rather than neurocognitive testing or radiographic imaging analyses of brain injury, which are potentially more sensitive indicators for neurologic injury after arch reconstruction. It has been shown that stroke after cardiac surgery is grossly underestimated by the operating surgeon when compared to a neurologist. And as I stated earlier, thus far there's been lack of a large-scale prospective randomized clinical trial. So knowing this, my former colleagues and I, we took it upon ourselves to do a pilot study, what we termed DRAMA trial, or deep hypothermia with retrograde cerebral fusion versus moderate hypothermia with antegrade cerebral fusion for arch surgery. This was done over about a 10-month period. 20 elective hemiarch patients were randomized to either DHCA with RCP or MHCA with ACP. We excluded redos, emergency procedures, i.e. type A dissection, those having more aggressive arch reconstruction procedures like a total arch, or those with an aberrant right subclavian artery. And the cases were done by two primary surgeons focusing on aortic surgery. The purpose of this trial was to define the incidence of neurologic injury following elective hemiarch replacement and to determine whether MHCA plus ACP provides equivalent or non-inferior cerebral protection to DHCA. The primary endpoint was a composite endpoint of stroke, TIA, or radiographic evidence of neurologic injury as assessed by MRI. Secondary endpoints included the presence of temporary neurologic dysfunction, neurocognitive deficits, or plasma S100 levels, markers of neurologic injury. So these are two primary study groups. The MHCA patients had all patients had right axillary cannulation. MHCA patients were circumrested at a nasopharyngeal temperature between 20 and 28 degrees Celsius. ACP was done at a rate of 10 cc's per kilo per minute. The nominant left cardiac arteries were clamped. This was a unilateral ACP study. DHC patients were circumrested at a nasal temp less than 20 degrees, and RCP was conducted in a standard manner of 200 to 400 cc's per minute. This table demonstrates the differences in the two groups, or the demographics between two groups, and essentially they were equivalent groups in terms of age, sex, other comorbid conditions, the presence of CHF, CAD, and COPD, and other neurologic or risk factors. This table shows the intraoperative data comparing the two study groups, and the as well as aneurysm size, concomitant operations, bypass times. Really, the only significant difference was the temperature at the time of hypothermic circular arrest, which was 19.9 degrees in the DHC group and 26.3 degrees in the MHCA group. Postoperative outcomes are shown in this particular slide, and it shows no operative mortality, no difference in the vent times, chest tube output, the need for transfusion. No patient had dialysis or kidney injury. One patient in the DHC group had a take back for bleeding, and hospital length of stay and ICU length of stay were essentially equivalent. Neurocognitive testing was done using the following parameters you see on the left to come up with a total composite score, and neurologic scores at baseline and post-operatively on day 7 and day 180 are shown here. And essentially, there was a slight decrease in the total score on day 7, which essentially recovered by the 6-month period. In terms of neurologic outcomes after hemiarch replacement between the two groups, if you look at the clinical evidence of stroke, one patient in each group had a stroke, which was not different statistically. 2 patients in the MHCA group had temporary neurologic dysfunction. This was looking at conventional means of neurologic assessment, clinical assessment, no difference. However, if you take the composite of stroke, TI, MRI lesions, 100% of the MHCA patients had evidence of a stroke either by clinical exam or the presence of MRI, DWI lesions, whereas only 45% of the DHCA group had evidence of a stroke, which was statistically significant. Not only did 100% of the MHCA group patients have a stroke, but the average number of DWI lesions was significantly higher at 4 compared to 1.2 in the DHCA group. And the volume of these lesions was different, but not statistically significant. So not only did every patient in the MHCA group have a stroke, they had more hits to the brain than the DHCA group. And this is what one of those DWI lesions looks like on MRI imaging. I want to turn quickly and talk about spinal cord injury and aortic arch surgery, particularly as it is impacted by the use of the frozen elephant trunk technique. Dr. Okita, 1 year ago, outlining the Japanese experience, multi-institutional study. And this is comparing patients in the orange circle who had frozen elephant trunk procedures compared to those that had total arch replacement only without elephant trunk. You can see the distribution of aortic pathology between the two groups was roughly similar. About 2/3 had non-ruptured thoracic aneurysm, whereas 15 to 20% had acute dissection, and chronic dissection of small patients, 5 to 6% each group had a rupture. So in comparing these two groups, the frozen elephant trunk patients were younger, and they had a higher incidence of emergencies, and they did have a significantly lower circular arrest time to the lower body at 51 minutes compared to the total arch replacement of a patient that had a 58-minute circular arrest time. But what was very interesting is that there was a significantly higher incidence of paraplegia, spinal cord injury in the frozen elephant trunk group compared to patients that had a total arch replacement only without an elephant trunk, despite the higher circulatory rest times in the total arch replacement group. And this was a summary that Dr. Okita put together in his paper at the time of all the recent clinical reports of frozen elephant trunk experiences at various institutions, and demonstrating that cord injury, spinal cord injury, occurs in approximately 2 to 6% of all cases of frozen elephant trunk procedures. The impact of this was demonstrated in one of the very first papers from Japan, and it shows the relationship on this is 24 patients, 6 of which, or 24%, had spinal cord injury, and this ultimately was related to the distal landing zone level and the history of a previous AAA repair. So in the bar graph on the left, spinal cord injury, the incidence increased the more distal the distal landing zone was, such that if you were the distal part of the graph was at T5, T6, no spinal cord injury, but then began to show its presence at T7 and certainly at T8. If there was a history of a previous AAA repair, 50% had a spinal cord injury, whereas only 6% had spinal cord injury without a history of previous abdominal aneurysm repair. This was another paper from Japan looking at risk factors, and this was an experience of 224 patients with a 2.6 operative mortality and a 3.6% spinal cord injury rate. And ultimately, distal position of the stent graft greater than T9, a lower mean blood pressure, and the presence of diabetes were all risk factor for spinal cord injury after the frozen elephant trunk technique. This is a meta-analysis by the Houston group looking at over 3,000 patients in 35 studies that they ultimately studied, or reviewed rather. And you can see the other summary of the patient demographics here. And when you look at their overall rates, the overall rate of stroke was 7.6%. The overall rate of spinal cord injury was 4.7% in this study, and mortality was 8.8%. And this is a visual summary of their findings at the spinal cord. The risk of spinal cord injury increased as you had larger lengths of stent grafts and coverage zones distal to T8, whereas it was protective if you stayed with a 10 centimeter stent graft or less and stayed proximal to T8. Certainly for the combination mortality, stroke, spinal cord injury, dissection was a risk factor for worse outcome, and aneurysm patients were more protective, although that difference was not found to be statistically significant. But what was significant, again, was increased stent graft length and more distal coverage led to increased risk of spinal cord injury. So in summary, the optimal cerebral protection strategy remains debated. No single strategy is proven to be superior. The true incidence of neurologic injury following elective hemiarch replacement may be higher than previously reported. Spinal cord injury is primarily associated with the use of frozen elephant trunk technique and the distal landing site. Optimal cerebral protection strategies will ultimately be defined by neuroimaging and neurocognitive outcomes as opposed to clinical stroke. Careful preoperative planning is essential for optimal outcome in the setting of a frozen elephant trunk procedure. Thank you very much again for your time and attention.
Thank you, Dr. Chen. That was an excellent talk. We don't have any. Oh, hang on. There's a question just coming in now from the panel. Oh, this is a comment really. So this is from the Dissection Awareness Patient Group. So this is on behalf of the Patient Association. They would like to thank the panel and the speakers for an excellent session that will move forward our thinking and practice in aortic dissection. Can I go on, Ong?
Go on, Debbie, you do first.
I was just sorry, thank you. I was just going to ask you, so what is your sort of cerebral protection strategy? Can you sort of tell us your cerebral protection strategy in acute aortic dissection? So what sort of factors would make you use antegrade cerebral perfusion as opposed to straight deep hypothermia and so on?
Well, Debbie, I think that for me, one of the first things is I want to establish antegrade aortic flow through the aorta. We saw the previous paper demonstrating increase in renal dysfunction with retrograde flow, and that typically is through the axillary artery. Sometimes we may cannulate centrally, with epiaortic ultrasounding, put the cannula on the lesser curve. So that's probably the first thing we do. Probably in elective surgery, we may cool to a nasal temp in the 25, 28 range. But I think in dissection, you sometimes don't know what operation you're going to do, in particular with arch reconstruction, until you open the aorta, look inside. So we probably cool a little bit cooler, maybe in the low moderate range, 20.1 to 24. Having said that, I think the preferred technique is still antegrade ACP, and typically for that's unilateral, to be honest. But I think if there's any dissection in the innominate or the carotid artery, we will just easily go to retrograde RCP, knowing it's roughly equivalent up to about 50 minutes or so. And then I think that if we find ourselves in the setting where we felt like we needed RCP in the beginning, but then we're going to do a prolonged a complex arch reconstruction with a prolonged circle rest time, we can certainly convert that to ACP in the middle of it. So yeah, I think it's important to be flexible depending on what the anatomy is, the patient presentation, and sort of the type of repair that you're going to do. Not really getting cornered into one technique, but just using all these these tools at your disposal for optimal outcome.
Thank you.
Excellent, Ed. It was a great lecture. And the one thing is that, you know, this your randomized study. It's a nice, very nice design study. The only thing is you got created an extra variable by going for deep hypothermia versus moderate hypothermia and the antegrade versus the retrograde. And then, so do you think the kind of the lesions that you see on the MR scan could be from the embolization caused by cannulation of the branch rather than actual kind of the perfusion techniques?
You know, you're right on. We wanted to compare sort of what at the time were the two main modalities performed in the United States. We recognize that in Europe and Asia the trends may be different. But I think that, and that's why we did axillary cannulation for everyone to take many of those variables away. Having said that, our technique for doing ACP was to encircle the innominate and occlude it so that the axillary blood flow would then go up the right carotid. And that manipulation may have led to a higher number of MRI lesions seen on post-op imaging, whereas with deep hypothermia and RCP, we did not have to manipulate that vessel. So that could be an explanation for that, to be honest.
What do you think about the branch first technique? Do you think that would reduce the kind of the embolization? I'm not entirely sure because ACP always come with some degree of integrating of the embolization with the cannulation or the manipulation, whichever way we try, isn't it? So.
Right. I'm not sure the branch first would work either, because I think the key, as you said, is the manipulation of the branch vessels. And I think irrespective of when that's done, they are being manipulated. And so those are concerning things to me. Perhaps it could be some combination of ACP, branch vessel manipulation, then RCP to flush out any residual emboli. But obviously, you know, time will tell and additional studies will be needed. All right.
And the one last question for me is about your spinal protection for your frozen elephant trunks. Do you routinely use spinal drains, or do you use any bit in the protocol in ICU?
You know, we don't use spinal drains routinely unless perhaps they've had previous abdominal aortic surgery. You know, we don't use the frozen elephant trunk universally. I think we're very selective, and quite honestly, are probably a little more conservative than some of our Asian colleagues and European colleagues. But I think that if they were to have previous aortic replacement of some kind, we might be more aggressive and place a drain. I think one thing we always want to do for those types of patients, irrespective, is just permissive hypertension, keeping the mean blood pressure 90 to 100 or so. And then if they have developed symptoms post-operatively, we may insert a drain, but typically we don't do that. But what we have done is obviously gone to a lesser aggressive length of the elephant trunk itself.
Great, thank
you. Right.
We do have one more question actually on the chat from the audience. Would you advise MRI brain as routine preoperative workup for at least all elective arch procedures?
You know, it's probably not unreasonable. We've talked about that because a person could have some pre-existent lesions that may not be recognized, and you know, in the MHCA, the ACP group there, a lot of those patients look completely fine. So, you know, of course, the big limitation is going to be available in cost. And so I think as hopefully a larger studies get done, similar studies on a larger scale in many institutions, I know they're planning those things, perhaps we'll have a better answer.
Do you do preoperative CT scans? Because I know there's some discussion about whether patients undergoing total arch, we should check to see if they've got an intact circle of Willis.
I typically haven't done that to check for the intact cervical willis or anatomy. We know there's a lot of collateral flow to both sides of the brain through the extracranial system. And so typically we've done antegrade and with using NIRS, both the oximetry has been equivalent in both sides. But if there is a drop off, we may clamp the left carotid artery to pressurize the entire system. And if there's still a difference, we may then use, branch manipulation with a catheter. But typically we've not done that because we just did not find that we weren't using that information to guide our therapy. It was more intraoperative monitoring that was being used to guide therapy.
Thank you.
One other thing to add now since we stimulated the discussion.
Yeah.
And when you kind of perfuse the brain in your pump setup, do you have a separate pump for the headline, or do you kind of split the line from your main pump, from the centrifugal pump?
We split the line from the main one. We don't have a separate one.
Okay. And so do you notice that when you restart your distal kind of perfusion or systemic circulation, cerebral kind of saturation drop for first few minutes?
We haven't noticed that too much, quite honestly, but we have tended that we're still, the perfusate temperature is still 18 degrees and it takes some time to warm up. So we haven't seen much of a drop in that, quite honestly.
Yeah. Depends on the setup, I think. Depends on setup. Very often you tend to see that kind of proximal, the flow, despite the flow probe, and tend to drop maybe, or they made a mixture of the oxygenated blood and causes saturation to drop for first 2-3 minutes, sometime maybe up to 5 minutes. Yeah.
Right. Yeah.
I think since that this is a dissection session, and before to close out with, I think, Ed, with your experience and your kind of leadership, what do you think these are important kind of the steps that we should put in place for any kind of dissection program to improve the outcome for our dissection patients?
Well, I think, having sort of standardized approaches, I think, it's a multidisciplinary effort between perfusion and anesthesia. I think the aortic first protocols in the UK are fantastic national initiatives to increase recognition of this disease process and expedite care. Similar to, there's an effort in the US with, STEMIs and getting to the cath lab quickly as a way to prevent the loss of myocardial muscle. So I think, a way to make emergency room, the first line is the first responders, paramedics, emergency room physicians, to be mindful of patients that this should be part of the differential in anybody who presents with an acute event. Dissection is very interesting, and that is the one disease process I'm aware of where history is very important to determine when the initial event occurred. Patients can always tell you what they were doing at the moment they were struck with chest pain. And so that's something that really should be taught to the first responders. Then I think, expediting care, if it has to be at a center of expertise. Some patients are going to be in tamponade and shock, and probably it's not safe to transport them. But if you have to transport them, going straight to the OR, having a system in place where patients can go straight to surgery if should something occur, that would be. So the initial parts, and then intraoperatively, obviously, there has to be, certain way that you monitor patients with the left radial, like the Swan-Ganz catheter, all those types of things. How you cool patients, the blood products that you'll use at the end, how you monitor for coagulopathy, and then the post-operatively in the ICU, keeping the mean blood pressure high to perfuse the organs. It's really an institutional-wide effort, quite honestly, that starts in the field and then goes to the ICU. So. And obviously there are many healthcare providers involved, but those would be sort of my initial thoughts.
Great, thank you.
Thank you.
Thank you.
We've been told that we're overrunning now, so I think we will sadly need to bring this discussion to a close. But I'd like to thank all the speakers and my co-chairs. Thank you, Dr. Chen, for joining us. Thank you, Ong, and thank you to all of the audience for joining us as well. And I think this now brings this virtual meeting to a close, and hopefully next year we'll all be able to meet up again in person. But I'd like to thank everyone for taking part.
Thank you.
Thanks very much.
Thank you.
Bye-bye.